Welcome, everybody, to this video podcast of the International Cardio-Oncology Society. One of the unique opportunities that we offer for members of ICOS is to apply for Center of Excellence certification. And one of the requirements for certification is that each program identify quality improvement projects that they have developed at their institution. These are programs that contribute in some way to increase efficiency in operations or especially improvements in patient care. And we've been so impressed by the quality of these programs that we wanted to share them with our community. And so one of the ways that we're doing that is by a series of podcast recording highlighting some of the gold standard programs. So today it's a pleasure to welcome Dr. Eric Yang, who leads the cardio-oncology program at UCLA in California here in the USA. So Dr. Yang, thanks for being with us and sharing one of your quality improvement projects with our community.
Thank you, Stephen, and thank you, Arjun and Dan. It's great to see you all virtually. And again, it's a real privilege and honor to be able to speak, about some of the efforts we've been making locally here at Los Angeles, about how we can, spread, the clinical care and, the importance and basically, the relevance of our field, I think, in a growing complex population that we know that the cancer population is becoming more and more part of, given the nature of how chronic the disease states are with better treatments and longer survival rates. And, this project is essentially a hybridization of what I'm very privileged and very fortunate to do, is blending two of the most rewarding things I do at my institution, which is both being a program director, which involves a lot of medical education and direct interaction with our trainees, but also being able to also run our cardio-oncology program. And in general, we know that many medical education projects, the metrics can be very murky and very, very tough to really gauge outcomes. But I wanted to talk about some of the projects and inroads we've been making to essentially not only expose our trainees and future generations of cardio-oncologists and cardiologists to the field of cardio-oncology, but also the bigger goal here is to address a great need that we know that the cancer population, as they live longer, will develop many other chronic complex cardiovascular comorbidities, whether it's from pre-existing risk factors or is acquired from all the old and new treatments that come about. And how do we really integrate this into systematic ways of, even general training fellowship? And I would say that, my personal philosophy about where our field is going really reflects that this is not just a subspecialty problem where the burden needs to, come, from us in terms of addressing these problems, but I think the general cardiovascular workforce and the hematology oncology workforce also needs to be aware of and have a basic understanding of how to address these issues, given the longer survivorship. So again, I'm very grateful for this opportunity. Here are my relevant disclosures. I would say the most relevant one related to this talk is that I am a full-time employee of UCLA Health, but also I'm an associate program director, and I've been very open about leveraging my role into expanding education to our cardiovascular fellows, hemonc fellows, residents, and medical students at UCLA. So my goal here, along with talking about some of our, our QI projects related to medical education, is, provide the rationale that our field, cardio-oncology, is a field that requires integration of education into the general training space and not just focused on subspecialty training, although that is also very important, and discuss some of the barriers and challenges we need to overcome to prepare the workforce for cardio-oncology and cardiovascular health management in the cancer population, and also talking about some of the work we are doing here. So I always like slowing the slide because I think this is the ultimate numbers argument for why our field is a very important one, because compared to a lot of other cardiovascular disease states that we need to know about, we have a growing and older and aging cancer population here, with an estimated over 20 million US cancer survivors estimated to be alive in the next decade or so. And you can see, if you look closely at the breakdown here, that many of these cancers, if you look at the lower half, used to be thought of as more potentially advanced, poor prognostic disease states, when many of them now are living longer with the advent of many new targeted therapies, immunotherapy, and also breast and prostate cancer patients may not necessarily die, from their cancers, but they may die with their cancers, but usually from something else. And statistically, our concern is that cardiovascular disease may take the mantle for the top cause of issues or health issues for many of these patients. I can definitely tell you, as someone involved in the medical education space, we know that these issues are not as well emphasized to our trainees, as well as to our colleagues and faculties as well, because many people have preconceptions of what cancer means for a patient, and many of them continue to view it as a more palliative, advanced, sort of disease state where cardiovascular interventions may not be, necessary or worth it. But we know that's not the case in cardio-oncology. And while I certainly have, don't have the experience or accomplishments as Dan and Arjun have, who have basically helped, evolve and grow this field, I definitely have observed some very interesting things for the past decade. And, based off of our meetings, based off our ICOS meetings and ACC and AHA, we know that interests have gone beyond tertiary referral academic centers. It has gone to the community where also most cancer care is. And we know not just within cancer, we know there's a huge relative lack of access, not just for cardio-oncology care, but for a variety of other fields within cardiovascular disease. Therefore, it's a good thing. We have become more mainstream, which is something we've always wanted. But at the same time, it cannot just focus on those who want to be cardio-oncologists. And this is, again, my personal viewpoint is that we definitely need to somehow integrate this into the general consciousness of our trainees, as well as colleagues who are now in practice and who want to provide this kind of care. So this core question comes, how do we integrate effective strategies to implement the growing science of cardio-oncology? Because if we can't deliver it, then all the science we do can only stay relegated to a few number of places. And you can already see here, and this is, I believe, a paper that is actually now out this week in JACC Cardio-Oncology, written by Dr. Taylor and Dr. Zaha from UT Southwestern. They have actually compared the distribution of cardio-oncology programs with places that, have the, both, and comparing it to the cancer and cardiovascular morbidity and mortality throughout the United States. And you can still see here there remains a lot of significant geographic gaps. And this is where, a lot of cardiologists are needed. But at the same time, we know that it is not a place that these are a lot of sections that maybe cardio-oncology may not make inroads. But if you have trained cardiologists who have some understanding or a recognition of needing to treat or send patients who need higher level of care for cardiotoxicity, this is an ongoing discussion that I think we all need to keep having about how to deliver care better to these places where there continues to be a lack of access. So this kind of goes to our question, and this is a photo roster of one of our general cardiology classes from a few years back. Should it only apply to those interested, or really should it involve, the entire class, and how do we do it with a very already compacted, training curriculum within 3 years? And then on top of that, do we also apply it to our subspecialty fellows as well? Because, you could theoretically still do cardio-oncology no matter what you go into as a quote unquote mainstream subspecialty. So I don't know if what I'm thinking about based on this is an unpopular opinion, but I don't think it will be a niche field. We still need subspecialty training. We still need specialists that continue to provide, really high level care for these complex regimens and cancer regimens. But I think we all should have a basic understanding whether we are going into cardio-oncology or not. And as you all know, this was a paper led by Dr. Alvarez Cardona and Lenahan and some of us on the AC Section Council of at least trying to approach this strategy of how do we integrate training and what determines competency. And this is a unique challenge because, again, we are a field that is completely dependent on another subspecialty. This is something that no other field has to deal with. And as a result, we have an extra challenge of also having alliances and relationships with another subspecialty field within medicine. And that's where the priorities and funding and support systems can vary from place to place. And we are obviously seeing challenges at a variety of institutions with this. And on top of this, I know as associate program director at UCLA, we're always having faculty from all different walks of life and specialties banging on our door and saying, well, the fellows need more exposure to this, or X or Y or Z. And then on top of all this, where do we integrate cardio-oncology? right? And the nice thing now is that the quote unquote research rotation has become more flexible in terms of electives. But then also, how do we mix that in also with people that also want to continue and get level 3 in imaging, for instance, or pursue more electives related to heart failure or other critical care electives? There's a lot of this is where I think, we have to have this ongoing conversation of how to integrate this on top of, other interests that our fellows may have that relate to procedures, imaging, and we make it, essentially an equitable experience for everybody. So there are obviously a lot of core challenges. Like I said before, we're dependent on another subspecialty. Right now, we are not quite there in terms of ACG accreditation. I credit the ICOS Society for making steps towards this process. But also, again, how do we integrate, this kind of training and knowledge base within a general fellowship? A standardized curriculum is something that we're all talking about how it's best to do and milestones. And of course, buy-in from both sides of the aisle. Another thing too is, well, what's the job incentive after training? And I know geographically it can vary from academic to community centers. And of course, the big bottom line is money in terms of support systems for further subspecialty training, program building, and allowing for space to provide research and clinical opportunities for programs to build their cardio-oncology, infrastructure. But also another obvious thing that we also have to deal with is we need robust evidence for a lot of the interventions that we do in this science, and it is literally changing by the month. We also, discussed this too, and this is also something that Dr. Ghosh was also involved in, where we looked at the current, the spread of experiences of our cardio-oncology, electives from some of our general fellows and subspecialty fellows, and we already made some proposals of how one could integrate using literature from, the ICOS document and other sort of proposed trainings documents on how to integrate, cardio-oncology experiences during one's general fellowship if they did not choose to do an extra year. And what we do here at UCLA is, I would have to say pretty standard, but one of the things is that I feel that is a really core requirement is, of course, to have a robust program to provide the volume for trainees that want to come in. And we definitely have at least 5 didactic lectures yearly for general fellowship, many of them done by me, and a structured mentorship program that is not just for cardio-oncology, but for, all our residents and fellows that have specific interests where they want to do with their career with the medicine residency. And we also, with the cardiology oncology clinics, we have the expectation that cardiovascular fellows also, help interpret the procedures and or stress testing and imaging that they order on their patients. And we also host external rotators to generate further, experience interest beyond our borders of UCLA. And also any procedures that are done, we obviously try to schedule at a time that the fellow is available to provide the continuity experience just beyond the clinic visits. And usually for our clinical fellows, they can come during their 3rd year when they're allowed to pick a clinic preceptor, and they're also allowed to come during their elective time. We also have a physician scientist track where fellows spend more years either pursuing usually a post PhD or PhD degree with their, with their basic science or translational sort of, their research experience. And they usually start their 2nd year, and they usually come weekly. And based off our numbers and based off the ICOS documents, as well as the ACC section council documents, we're able to achieve at least level 2 competency for both these tracks. And also scholarly projects are obviously encouraged, tailored to interest. I love this field because there's so much low-hanging fruit. Anything you want to tackle, usually there is something that's investigatable, and almost all do at least one poster or paper. And again, like I said, really, this is really dependent. Again, you need the volume, you need the experience, you need the diversity of patients. And I think because of the support and the collaborations we've had with the Johnson Comprehensive Cancer Center, even despite, COVID pandemic, we leveraged telemedicine to really expand our reach into the California regions and beyond. And we definitely have continued to grow. This is my personal volume. This is just my personal volume, not including my colleagues here, and having to open up more half days, which allow for more fellows and residents to attend and participate in these patients. One particular, and this was from a few years back, one of our fellows, Dr. Brian West, who is now in San Diego at Sharp Center, he himself, over the period of about 2 to 3 years, saw at least over 167 patient encounters, over 100 unique patients in the time he was a fellow. For us, most of our sick patients tend to be hematologic malignancies. And you can see here, we basically see everybody here. I mean, this is a variety of just a breakdown of all the different malignancies and the types of chief complaints that we have. Dr. Ohada Oren, who is now an MGH fellow and doing now, I think, his research component there, came to see us, rotate with us for 5 weeks. He also admittedly wanted to enjoy some Los Angeles sun, coming from Mayo. But also in the time he was there, he was able to see 66 patient encounters, again, mostly hematologic malignancies. And we know as the years progress, we know the demographic, especially with more and more immune checkpoint inhibitor and T cell therapies, we're seeing a shift. And this is also what makes the educational exposure always so dynamic and what we need to stay on top of. And this is our project where we have offered this, again, this training elective, and as a result, accompanying, elective, and scholarly not expectations, but scholarly, projects that come with it. And these are all the fellows, since we've integrated this training experience, of all the fellows that have gone through the program. And really, again, I have to say, these are the people that keep me motivated. They're the ones that keep me invigorated. And, from our output so far of all these fellows that have gone through the clinic, and I'm not even including medical students and residents who have also rotated through, we've had at least 5 fellows start cardio-oncology programs at their institutions. 4, and now I think 5 are now UCLA faculty and provide clinical cardio-oncology services in a vast network of UCLA. And we have also now 4 physician scientist trainees faculties that have cardio-oncology as a primary research interest. So, again, like I said, the metrics of medical education are always tough to say. But again, this is our efforts to really, again, at our level, to really try to expand interest as well as the workforce to address these issues at all levels, clinical and research, to do this. And I can tell you, just from doing this now for about a decade as an APD and in the field, inspiration really comes from exposure and immersion. And for all of you who have the ability and privilege to work with trainees, don't underestimate, even a minimal amount of exposure can get anyone inspired. Like, even if they rotated with you for a couple of weeks, you don't know where it's going to take them. And we have seen even residents who did a few things with me also continue to do it as a clinical project or a clinical career. And also from our research output, I am listing papers or abstracts where trainees were first or senior authors, not any of necessarily my publications, but we've had over 50, peer-reviewed publications since 2016, and book chapters, and a frequent representation at national meetings. Again, essentially voluntary, but again, just showing the interest that, that is generated when house staff have this kind of clinical exposure at the general level. We also have had a lot of involvement at the ACC California chapter level as well. This was a webinar that was where Stanford was running mainly the discussion on VEGF-induced, cardiotoxicity. But, if you look at the bottom row here, you see 3 UCLA alumni that are involved in discussion: Brenton Bauer, who's now in CORE, who's one of our fellows, who's the Cardio-Oncology State Chapter Chair; Evelyn Cheng, who was one of my residents and mentees, who's now a Stanford Fellow; Nikhil Basi, who's down at Hoag, who also did cardio-oncology with me and now is doing it in Newport Beach. So it is possible in every setting. And what we have learned is that, for me, that preparing the workforce for the growing cancer population will likely need us to train everyone, not just a few. But obviously, it is possible, but there are several requirements that are needed. One is a pre-existing robust volume to ensure a diverse, adequate exposure. And you always need champions within medical education and fellowship, with frequent exposure interactions with trainees are essential to gauge the pulse of what they think is relevant and what they want to do. And integration of teaching, as well as involving not just the clinic experience, but the inpatient, the imaging, and the procedural aspects, because you're going to have a lot of trainees who will have other different interests of, procedural fellowships, and you can have them have this hybrid type of interest. And we've had a few that have gone on to other fields that are able to integrate cardio-oncology into their practice. But ultimately, to me, it's not a complicated process. You just need to get them involved. You need to show that, you care for these patients. The pathology, as we all know, is fascinating enough, and this will inspire further clinical interest and scholarship. And again, I want to thank, both my local institutional colleagues and mentors, and really, just numerous people over the years who have made this trip possible for us, and the support systems. And again, one of the unique aspects of UCLA is we work with one of the biggest cancer centers in the country, but as a result, we are also working with some of the biggest geography that one or two people cannot do it alone. And again, I'm thankful for our team here who have been able to handle the vast cancer volume throughout and beyond. And you could see here, 4 or 5 of these faculty or some of our fellows who worked with me. And, this is something that we hope that will hopefully address at least the issue of cardiovascular care in the California region. So again, I really appreciate the opportunity to talk about our initiatives here, and I'm happy to chat further with you all. Thanks again.
Dan, Arjun, thoughts?
Yeah, so Eric, great presentation, and thank you for all those details. I think that it is important to continue to reach back farther or earlier and earlier in the educational process. So like you said in your presentation, it could just be a small amount of exposure that inspires somebody. So I think that it's always better to inspire them earlier. And I think that that's a very true statement. So I appreciate all your efforts there. Arjun, I'm pretty sure you have exposure to lots of trainees. I don't know how you see Eric's paradigm of how they organize things.
Yeah.
What might apply to what you're doing.
Yeah, no, really interesting and really inspiring, Eric, to see the work you're doing. And I think I'm probably in a similar position to you. So I'm a training program director and then the lead for cardio-oncology at UCH. So I think we've done something similar, but I guess, one of the questions maybe that I had was one of the initiatives that we took was to integrate this into the UK National Cardiology curriculum, both at a general cardiology, early training stage, and then integrated it into the advanced curriculum for heart failure trainees. So basically, every UK trainee now has to train in cardio-oncology. Now, at a general stage, obviously, we're not talking about in-depth training, but they need to have some exposure. They need to have attended some clinics, etc.
Sure.
So I think, I'm not obviously completely up to date with the US training system, and I understand that it can vary from state to state, and then you have your national boards and things. So I don't know. I mean, what do you have any comments about how, can this be rolled out nationally? And I know that there's been a lot of, ICOS obviously is doing a great thing to have a, certification program, but what are your thoughts on a national kind of training level in the US?
That's a great question, and I applaud you and your colleagues' efforts, especially in the UK, to kind of spearhead this, because I think in the United States, we don't have that level of, I guess you could say, unity in terms of that. But at the same time, I also understand that not every training program necessarily has the same inroads and access to the cancer population, and to be able to instill the same levels of training. And I think that's probably why we are not at that level yet, where it's basically, I guess you could say, it's mandated to have that exposure, right? I mean, I think we're probably viewed as a level, same thing as a very subspecialty field. And it's the same kind of rationale that obviously for instance, not every training program has access to, say, heart transplant or structural valve interventions, because they don't have the volume or the capacity. And we don't have the same degree, I think, of setup that necessarily every program. This is frankly something I encounter when I give talks at other hospitals, is that there's just a lot of difficulty, I think, in engaging the other side of that, which is why I do think the main prerequisite that needs to happen first is that you have that volume. And it makes sense, same thing with a lot of other fields. You can't have a TAVR program if you don't have a certain interventional volume, right? You can't have a PCI interventional program, et cetera, et cetera. So from our standpoint, that's the same thing. But but how much of each kind of cancer, how much of kind of, I know, I'm sure Dan, you and Arjun, we've all kind of had these conversations. And also, as you remember from our JACC Cardio-Oncology publication, all the different trainees, all the, you saw the different kinds of the malignancies and the demographics were all over the map at different, institutions all across the United States and the UK. So there really is no, uniformity because, again, we have a different level of complexity of dealing with a patient population that varies from institution to institution. So I think the challenge we have is that if we were to somehow hypothetically say it has to happen, you're still going to have a lot of varying degrees of experiences. And I think it needs to be more, I think this is sort of a chicken or egg problem, I think, is that you need to have the system set up, but how do you go about doing it without support? Because I think if all programs had the same equal amount of support to be able to build programs to have that exposure, then I think we could be where you are, you guys are at, but we're not,
Yeah,
I think it's a challenge. Sorry.
Yeah, I mean, I don't think maybe it would be wrong for me to say that in the UK, this is a kind of very well established, every center or every training program has cardio-oncology service. But what we can do and what we do is, given that it's come into the curriculum, is if your local training program is unable to offer the cardio-oncology component of it, can be hosted in another, training program region for that period. And for general cardiology, we are talking about maybe a 2-week block where they have the outpatient service and the inpatient cover. So is this, I mean, again, like I said, I've not gone through the US system, but is this something that, would be possible, or how do you foresee, because definitely the US is leading in terms of the number of cardio-oncology services. You have far more cardio-oncology services in the US compared to any country by far. So I think, as you mentioned, Eric, that the interest and the awareness is definitely growing, but can that be leveraged into something like that?
Yeah, and as you see, on the in the American College of Cardiology website, and there are opportunities that a lot of programs are openly, advertising, to say that, if you want to spend some time with us, I can think of openly, like, for instance, Penn, St. Louis, some of the bigger programs definitely are available for that. I think and I think this is, again, more probably not necessarily, openly advertised, but the nice thing about, I think, within the United States is that residents, as long as you are a state certified, board certified physician, you actually theoretically could go to do rotations at any other training program. So what, for instance, even within Los Angeles, a lot of our fellows cross-rotate at other places if they can't get the experiences they need, like going to other institutions for CT or MRI or heart, the programs that can't get as much heart failure transplant come to us, for instance, or adult congenital. And we've hosted, like I've shown here, external rotators. In fact, next month, I'm hosting two, one a medicine resident, one cardiovascular fellow from another program. So it just requires some paperwork, and it can be done. It's not something I think that's necessarily, I would say, in the United States just openly talked about, but it's very possible to host outside, trainees to do that within the United States, as long as you fulfill certain, board certification and, no, sorry, state licensing requirements. I apologize, not board certification, but state certification. And so that is also another opportunity that people can have. And we've also offered that as well for people that want to come and work with us. So,
But there's always the paperwork involved, which is the same here in the UK as well, unfortunately.
Right. But that's honestly it's a minor amount of bureaucracy for hopefully a very meaningful experience. And I think that's one of the nice things, at least within the networking within the medical education system, that is very possible. And we openly encourage that. And we have plenty of cancer patients for our physicians and residents to see. So I think that's always a great opportunity to, again, get them in the thicket of it and then see what gets them, inspired. And like I said before, as you all know, there are so many facets within cardio-oncology science that you could go tackle any aspect of it. And even at any institution, any kind of analysis or look can help somehow inform the field.
So I just hope after this, if you get overloaded with requests from trainees to come to UCLA, Eric, you can't blame anyone but yourself.
Yeah. No problem. We're happy to have them. We have an overload and we have an overload of patients. So, but But we also hope to, again, obviously not to make it just about, just the patient care experience, but also, again, just to know the kinds of patients. And again, I joke about this too, because I think trainees are at a point in their life where the unknown still excites them, unlike the rest of us, right? So like, our call, but of course we're in a field where we're always challenged, but this is a time where they're very, very, very approachable, and they say, hey, this, like you all know, it just takes one case of immune checkpoint inhibitor myocarditis to get everyone just their eyes lit up and go, my gosh. I know a couple of my own fellows who went into the field just because they encountered it, just one or two cases of it, and it completely like blew their minds, about it. And
I mean,
it's just
yeah, absolutely, absolutely. And I think, Dan has done like a tremendous amount of work with the original papers on, training in cardio-oncology. And I'm sure, he can definitely give us, his thoughts on how best maybe to take things forward. I don't know what you think.
Yeah, well, I think what you guys are talking about is really fantastic. And as mentioned earlier, getting earlier into medical education is key. And at some previous institutions, I actually gave lectures to undergrad students. Well, if you really want to you take a doctor and go to an undergrad class, it's like, oh my, I am so out of water here. I don't know. I don't know exactly how to talk to these people anymore. So I think that, but I do think that all these efforts are really important. But I would like to transition a little bit to what I consider kind of the main frontier right now. And Eric, you brought this up in your slides, where most of the substantial majority of oncology care is provided outside of academic places. So really where we need to continue to push the forefront is in clinical practice outside of academic centers.
Absolutely.
And so it's great when you're thinking about fellows and how you can organize their schedule over a 3-year period. And I think these efforts are tremendously important. But honestly, it's a bigger population when you're talking about how do we make a provision for training for people that are out of their fellowship.
Yes.
They've already gone to practice. Maybe they had some interest that was kindled by some exposure they had in their practice. How do we make a provision for their training? And I think that population is quite large.
Yeah. And Dan, you've been in this and been a bigger advocate than anyone I can think of. And I think, the big picture strategy that I can only think of, frankly, is peer pressure, right? I think because I have a lot of my former fellows, some who want to do cardio-oncology and some who maybe have a passing interest in it. But I think that even in academic centers, sometimes we are viewed as sort of the awkward stepchild between cardiology and cancer. Like they know what we're doing is important, but they don't really quite grasp really, sort of like our role in cardiovascular disease. I mean, some of my mentees have interviewed at places and they're just kind of like, well, what's the point of this? Not understanding the vast cardiovascular burden in cancer, right? And it's the second top cause of death in many states and countries, and as you know, but yet cardiovascular disease is a top killer. But I think a lot of people just don't see that connection yet. And yet this is a huge population that makes up a lot of healthcare enterprises. And I think when you have community, healthcare systems that eventually appreciate this, then there will be support to provide, hopefully, avenues for ongoing self-learning or opportunities or support to get trained, right? Like, I mean, again, I'm just gonna take examples from my interventional colleagues, right? If they see the value of a procedure technology, some places or some groups will pay their colleagues to go get trained or go for them to do it, right? Or give them protected time. But yet, I don't think that's probably the situation for cardio-oncology. But if they realize that understanding how to integrate, imaging protocols and knowing how to have, referrals for certain kinds of high-risk cancer regimens for people that may be at increased risk for cardiovascular disease or issues, if practices understood the importance of that, they probably would support their doctors in doing this. And I think more continued national pressure of not only talking about the science, but also sending more people who are more aware of this stuff out into the communities and saying, hey, I need time and I need protection to know about these things, to learn from these things, from ICOS or coming to these meetings or ACHA. I think it's a gradual campaign to get people more aware. But I think that's the issue is I think recognition and appreciation of our importance, I think, is the major challenge. And also, and I hate to say this, we have to make it financially sort of relevant. This is what I think this is a lot of healthcare systems understand, feel value they can bring in terms of, revenue or volume. But I'll be honest with you, cardio-oncology can be a field that can do that because the cancer volume at many centers is a big proportion of what they make up. And there's a lot of opportunity to integrate multidisciplinary care to improve outcomes. But the question is, they have to see it, So I hope I answered your question. But I feel like once these centers appreciate it, then they'll give the support to also provide ongoing education and training. But I think that's a major challenge of what we need to do for a lot of these these centers throughout the country.
Yeah, I think that we are attempting to address this at least at one level, but just like with just education at the medical school or at the medical level, talking to fellows, going to residents, go to medical students, and even earlier, it's multiple strategies. You're dealing with many different levels there. In the clinical practice realm, I think we're also trying to address many levels, but one level that has recently been initiated by ICOS is to develop a master's program. And we are, we have online training, and then we're identifying clinical mentors to help, exposure to the whole space of cardio-oncology to a practitioner, and not taking them out of their practice, but integrating their education into their practice. And so I would say that we're not quite fully organized in terms of how we're going to do this, because we're trying to do it in many different locations. And so each location has its own specific challenges. So I think we're very interested in what you're doing, and I think this podcast is awesome. It's really kind of highlighted both from a US and a UK point of view. How can fellowship and residency programs really take things forward? I think we also have to look at the practice level. How do we do that in all the locations and where patients are being treated for cancer, which is everywhere? So
and I totally agree. And I think, this, I can tell you, at least at this level, one, there are some things I think I was very privileged and lucky to have at an academic center. Number one, we have an affiliation with an NCI center, and everything is centralized in a sense of communications, coordination, navigation, etc. It is a bit more manageable to communicate with our oncologists about, getting care or, getting cardiovascular appointments in. So that definitely is an advantage we have. But, the strategy I employed, and I think, Arjun has a kind of a question about this. Was it easier for me to offer this being a program director? It was, I will say, as I said before, I leveraged my position to integrate this. And this is why I say it's important to have a figure on your team, if it's not you, that has face time. I cannot emphasize how important it is to always have someone sort of in the presence, exposing them to talking about the science, about the patients, because even little things like you can integrate cardio-oncology not just within didactic lectures. Whenever there's a fancy, like a phenomenal, interesting case in the echo lab or in the cath lab, you can say, hey, you should talk about this during one of our fellow presentations, not just within cardio-oncology. There are other indirect ways you can spread the gospel through other sort of, other teaching lectures that trainees have to do. And then that's an indirect way of how they get further exposure. But someone has to be there to push them or to kind of guide them to do that. And, I did this with the least amount of support needed, because I just kind of took my volume and then made it available to our trainees to put themselves into, instead of saying, I need X amount this to provide, space for these kinds of patients and things. And this is something that doesn't occur, frankly, overnight. This is years and years of investment. So, and as you know, we all tell a lot of new trainees who want to come out and do this, they have to be patient, because it's not just, it's not, the unique aspect is you have to not only get buy-in, but you have to have relationships with your cancer colleagues to be able to start, so they can entrust you with the care of these patients, then being able to teach others, whether it's residents, trainees, or fellow cardiologists, about the care of these patients. So it was a more quote unquote thrifty way of integrating it into an already established system. But I can tell you it is possible to do, but you have to have certain things set up in order to make it, successful. But it is a long-term investment process.
So Arjun, you want to give us final thoughts on this? This has been really amazing, and I love hearing about all of the ways that you guys have improved your programs, and I think it's a great example for the rest of us.
Yeah, no, thanks, Dan. I mean, really nice hearing about the experiences everywhere. And I think I echo your comment about catching them early as medical students. So I've had a few medical students come and do their 2-week electives with me in cardio-oncology, and they then managed to actually with my help, set up the British Student Cardio-Oncology Society. So they actually formalized this.
Awesome.
Medical students, so we have around 10 medical students across the country, and they are trying to help us from the British Cardio-Oncology Society viewpoint as well. So I think, yeah, any time we can be advocates to medical students, to trainees at any level, as Eric mentioned, definitely I think that's one of our roles. But really nice to hear everyone's experiences. And thanks once again, Eric, for telling us about the excellent work that you're doing in your program, and for sharing that with all of us.
Thank you for having me. And again, for anyone who watches this, again, thank you for your interest, and I'm happy to chat and strategize. I think that is at the next level. What we all need to do is help each other out to really, again, not only inspire interest, but again, to prepare the workforce for such a large population everywhere.
Fantastic. Thanks so much, Eric, for sharing your experience with us.